Clinical Director, Dr. I'd like to welcome you all to the PICS Annual Forum for 2024 as we celebrate our 20th anniversary as a service improvement network for children's cancer in Victoria. I would like to begin by acknowledging the traditional owners of the land on which we are meeting today, the Wurundjeri people of the Kulin Nation, pay my respects to elders past, present and emerging, and extend a special welcome to any Aboriginal or Torres Strait Islander guests in the audience today. Over the past 2 decades, the PICS network has defined service capability and optimal care in childhood cancer in Victoria, developed capacity and capability in regional Victoria to support families to be treated closer to home where safe to do so. We've built the statewide survivorship program, delivered education to hundreds of health service staff, and developed nearly 200 information resources for families to support their knowledge and understanding of the treatment and supportive care options available to them. We have focused projects in the supportive care space, from home-based care programs, nutrition, and procedural support. We've achieved all of this work through partnering and collaborating with teams across Victoria, and with strong engagement from parents, patients, and consumer advocacy groups. We have an excellent panel set to speak with you all today about their experience in both providing and receiving family-centred care in Victoria, who we'll introduce you to shortly. But before we do, I have a few PICS programme highlights to share with you today. So PICS houses 3 distinct teams: the Service Improvement and Data Team, the Regional Outreach and Shared Care Programme, and the Long-Term Follow-Up Programme. Focusing first on regional outreach, I would like to start with a special welcome to some interstate colleagues today. We have the privilege of hosting the Sporting Chance Cancer Foundation nurses from New South Wales and Queensland, who are meeting with the Victorian Regional Outreach team to share best practice in regional care delivery. We thank Sporting Chance for their continued financial support of the PICS regional programme over the last 16 years. Also in attendance today from Albury-Wodonga, we have the Regional Nurse Coordinator, a position funded by the Albury-Wodonga Regional Cancer Centre Trust Fund, as a pilot just under 2 years ago, to complement and partner with the regional programme based in PICS, working together to coordinate care for families in the northeast of Victoria, and with very positive feedback from the families who are utilising the programme. The project has just recently been selected as a finalist in the Victorian Public Health Awards in the Care Close to Home category, which is a fantastic recognition for the importance of regional care delivery in childhood cancer and the combined programme overall. And then finally, in the regional space, we're excited to announce that following the Children's Oncology Group meeting in September, formal approval and governance is being granted to support aspects of COG trial delivery to occur in the regional shared care centres. This is a great advance for regional families, many of whom historically have had to make very difficult decisions about whether to stay on study in Melbourne or come off study to be able to receive care regionally, closer to home and closer to their support networks. Moving on to the long-term follow-up programme, which is celebrating its 15th year this year, supporting childhood cancer survivors and their families, and therefore has been a significant part of the PICS programme over our 20-year history. The LTF programme is grant funded by the Victorian Government and has supported over 2,000 patients in that time. Today, the programme runs 4 clinics a week with a multidisciplinary team of nursing, medical and allied health staff to support the management of the late effects of cancer and cancer treatment. We'll hear more about the impact from our panel member Lucy, who will speak about her personal experience in the programme. And finally, in the service improvement space, which is PICS core business, as we say thank you to our exiting clinical director, Dr. Greg Wheeler, and welcoming Dr. Kanika Bhatia into the role. We're looking forward to the next decade of PICS impact in improving cancer services for children and adolescents. To this end, we are developing the nursing curriculum for paediatric oncology in collaboration with our member health services and with the support of the AMCHOG Nurse Education Group. Through our partnership with the Victorian Paediatric Cancer Consortium, we're finalising our Victorian Childhood Cancer Outcomes Registry, or VCOR, which will utilise diagnosis, treatment and survivorship data, along with patient and family reported outcome and experience measures to facilitate service improvement and research. And finally, we are currently developing our next 4-year set of strategic priorities with you all to align PICS with the new Victorian Cancer Plan. We have a live survey that we will share a QR code for at the end of this forum, and I encourage you all to provide your thoughts about how we can continue to improve the services across the state. So I will now hand over to our panel facilitator, the fabulous Cinzia De Luca, who is the team leader of the psycho-oncology team here at RCH. She will introduce our panel members and lead a discussion on the theme of family-centred care.
Yes, so that's working and people can hear me. Thank you so much, everyone, for joining us today. It's lovely to see so many familiar faces in the audience, and I'm very privileged to host this panel discussion on a really important area, which is family-centred care, particularly important in paediatric care, and especially important, I think, in terms of oncology care. And really, it's one of the pillars of the mental health strategy on the campus, because we recognise how important treating the whole family is to improving children's outcomes, because they sit within that ecosystem, and it's particularly important to how they do in terms of their psychological wellbeing going forward. So I often joke with my colleagues that relationships with oncology families are a bit like a long marriage. There's a lot of compromise, there's a lot of decision making, there's a lot of downs, and thankfully in childhood cancer there's also a lot of ups to celebrate. But really it's a partnership, and I think that's a key component of family-centred care. Sometimes we hear people say, you know, can't give parents all the decision making. You know, what about child-centric care? The child has to have a voice. There's no reason why we can't do those things in parallel. And really, this is actually about making families feel like they're active partners and active contributors to their child's healthcare journey. And as healthcare professionals, that's really our role. So I think we're all striving to do that well. There are some core components to that, to achieving good family-centred care. One is respecting families, and that's in all the beautiful shapes and colours that they come in, and understanding that some families are composed of grandparents and aunties and uncles and cousins, and including all of them really in how we do things. It's also about understanding the families are probably the best in terms of understanding their child and their needs. And so making sure that we check in around that. So open communication about everything we do with families and patients is really important. And then showing compassion. And I think sometimes we forget this is probably the most traumatic experience that you're going to experience in your lives. I love Liz Dawes once said, you choose this as health professionals. We never chose to come to oncology and be in a cancer centre. And I think that's something that we need to remember when we're providing care to families, really important for us to reflect on. So we need to be respectful, open communication. We need to understand that maybe we don't see people at their best a lot of the time because of the pressures that they're under. But I think if we can do all those things well and feel like families are coming along with us on the journey, as opposed to us doing things to them and to their children, then the outcomes are phenomenal. So we can get excellent quality of life, and that's because people are satisfied with their care, both parents and children. They feel like they were in control. They have better satisfaction generally in terms of life outcomes as well. And we know that even their engagement longer term in survivorship care is better because of that journey that they had. So I'm delighted really to welcome the panel members today, each who are going to provide a different perspective, some who are lived experience advisors for us and some who provide care to families and young people. And I'm going to start off with Cheryl Elliott. Thank you, Cheryl. Cheryl is mother to Hayley. And Hayley was diagnosed with acute lymphoblastic leukemia in October 2018 and was treated at Monash Children's Hospital until 2021, I understand. She went through intensive treatment, and Cheryl's going to share some of her experience of, I believe, a nasogastric tube being introduced as part of that journey. Thank you, Cheryl.
Hello, and thank you firstly to the PICS team for having me here today. So, My daughter, as you said, Hayley, was diagnosed with acute lymphoblastic leukemia in October of 2018. She had only just turned 2, and she's a twin, and her older sister was 6 at the time of diagnosis. As you can imagine, my husband and I were thrown into turmoil. But even though we're in a very dark place, we always felt that we had the support of the oncology team and that we were given all the information that we needed so that we could make a really informed decision about her care and what that looked like. So I'd like to share the other story that happened to Hayley. We're in the intensive therapy stage of her treatment, and we're just about to finish, and we'd been in hospital for a very long time. She had lost her hair and she was losing a lot of weight. Was feeling very sick at that time, and it was at that point the dietitian came in and said, we'd like to put in a gastric nasal tube. And my heart sank. I felt completely defeated. I knew that it was a medical intervention that had to happen, that there was no other choice, that it was either put the tube in and she puts on weight, or we don't, and what would that look like? So I was quite against it, but didn't want to cause any trouble. I wasn't about to get angry and say no, but every inch of me kept saying, I just can't deal with this. I was at the complete end of my emotional sort of journey myself. I just had nothing more to give. And I thought, how can I support this little bub to hold her down again and have something done to her? And her eyes just looking at me with freaked out expression of what's going on. So for me, it was just a very emotional decision. And look, we were prepped throughout the whole day. We were given all the information that we needed, how to manage the feeding regime, what the procedure would go, how it would go, what we would be experiencing. So we were given a lot of the really good information and we were supported. A lot of the nurses kept saying to us, it's fine, kids adjust, it'll be okay, it's not a problem. But for me, who'd never really had to deal with it and was emotionally unable to cope, I was just at a point where I was just like, I just can't do this. It really represented to me the conversations from strangers that I'd have to have, that Hayley, yes, she'd lost her hair, but people were still not coming up to me and asking questions, but that tube was just this physical representation of, you know, how sick she was, and her sisters would be kind of a little bit freaked out about it, and it would put this wedge between them that was already there emotionally, that it wasn't going to be a normal family sitting down to dinner. It would be just another step, a medical step that I'd have to take and have to deal with, as well as all the medications. Maybe it was an irrational kind of thinking process, but that's where my head was, I guess, at that point in time. Waiting for the procedure to happen. It was very late in the afternoon, and the oncologist came into our room. It was about 4 p.m, and he said to me, "We're not going to go ahead." And I just was in such relief. And I couldn't believe, well, there's no other option. How could this happen? And he just said, look, we're not going to put Hayley through another traumatic experience when, for one, she's going to be finishing the intensive chemotherapy stage. So she wouldn't be feeling as sick, not as nauseous. We're moving into the maintenance phase. So we're going to be going home. She'd be with her family and be encouraged to eat. She could have more options than just the hospital food, even though we tried to bring in as much food as we could to help her. She could just go to the cupboard though and get whatever she wanted. So all of these things, I felt reassured that it was the right decision, and I was just so greatly relieved. So I wanted to say how grateful I was to the oncology team for being so compassionate and for looking at a holistic point of view of our family, and to look at Hayley as an individual, not just a medical protocol that she reached a certain weight, therefore we put a tube in. You know, it wasn't just that they looked at the whole picture and said, it's going to be okay. And, you know, she was going back weekly for treatment, so she was being monitored, and we weren't just let to go home and not be looked after still. So thank you to the oncology team. And I'd like to say that Hayley is 3 years off treatment now, and she's an 8-year-old in grade 2 and has no side effects from the treatment. So thank you for listening to my story.
Thank you so much for sharing that, Cheryl, and I'm glad it was such a positive outcome for you and the family in the end. And you're quite right, we look at nasogastric tubes every day, but it's important for us to reflect on how significant really a sign that is for families around illness and how their child is doing. I'm going to come back to you later because I noticed that you said you didn't want to make trouble. And I think it's really interesting when we're talking about family-centred care and allowing families to feel like they can bring up these concerns with us without being a problem family or a difficult family. And that's a really pertinent point for us. But thank you so much for sharing that. We're lovely to hear that Hayley's doing so well. So next up, we're going to go to a couple of our healthcare clinicians, Kate Vandenberg and Karen Jolly, who are both from Monash Children's Hospital. Kate is a nurse practitioner and Karen is a child life therapist, and they're going to share some of their clinical insights to working with families. Thank you both.
Yeah, thank you for the opportunity for Karen and I to be involved. When we were asked to talk about family-centred care, what really first came to mind for us was really how closely we work with the families during the procedures and trying to support their child or adolescent through the many procedures that they'll have through what can be quite a lengthy period of treatment. And Karen and I have worked together for a number of years now, and she's probably sick of me, like most of my team, but we get along pretty well. And we had a bit of a laugh together when we were reminiscing about the different characters that we've worked through throughout the years, and just how creative we've often had to get when really being able to provide an individualised approach to help support the child. And there was a particular patient that really did stand out to us, and I think it's because it was a very unique experience and it was quite a learning curve for us and the team. And this was a young boy who was 8 years old, and we'll call him Frankie. And he was diagnosed with T-cell ALL, and he also had a diagnosis of ASD, and he lived with his mum, who was a single parent. And I think this particular experience really highlights how we recognise the family as a very essential and active partner in the care of their child. And we really have to gain an understanding of their values, their experiences, and their perspectives and their strengths. So the multidisciplinary team worked very closely with Frankie and his mum, and this was to learn how to communicate with him, how to connect with him, and really to be able to meet his information needs. And this is where Karen was really able to build that partnership with Frankie and his mum.
Thanks, Kate. Yeah, when Frankie came into clinic, he was really nervous, and it was really obvious that he was really nervous. So I think the first thing I wanted to do is just to help him feel more comfortable in the hospital space. It's obviously a really different setting for kids if they've not been there before. So with Mum's help, we got to know a little bit about him, and he had a very, very special interest in trains, train stations, and more particularly transport routes. Absolutely loved plotting transport routes from one train station to another part of Melbourne. It was a really special interest. He also asked a lot of questions, and it was quite obvious that when we answered those questions, it actually really helped him to settle in the space and give him a little bit of predictability and control. So they were two of the things that we really noticed. Mum was really on board. She was a great partner with us, and actually brought in the Melways, which, if people remember, the Melways was the old transport book before Google Maps. And we brought it into the treatment room with us, and when he had his port accesses, we would plot the route from various train stations to different points around Melbourne, and he'd quiz the nurses, well, how would you get from here to here? And it was really fun, actually, and quite a funny, joyful experience that worked really well. He also had lots of questions, and I think when you're a child or probably an adult in the hospital and you have a lot of questions, it might feel a little overwhelming about how to get those answered. So I just, as a child life therapist, was able to help him a little bit to make a list that he could take to the doctor, or to find a nurse at an opportune time in clinic when the nurses are running around busily. You can't always get your question answered when you want to, so maybe holding that and helping him find someone at an appropriate time. He was also incredibly fascinated about where his blood went when his blood was taken. So we had a bit of a look at the pathology chute and watched the blood tube travel up, and whoosh, up it went, which led to a lot more questions, because where on earth does that go when the blood's shot up the pathology chute? So again, got a little bit creative and rang someone in pathology who I think was thrilled to find out that there was a child who was interested in their work. And we actually went up to pathology and spoke to one of the pathologists to explain some of the machines. So that was lovely as well. So we were having some really great successes actually with Frankie, and just really helping him in the space. But there was one area that we hadn't made those great wins and had that great progress in, which was when he'd come in for his general anaesthetic. So he was really frightened at that time. And I think from the relationship that we had developed together, he actually shared with me one day that when he had the anaesthetic, he was very worried that he wouldn't wake up from that anaesthetic. So I can't remember how I responded at the time, but I knew that that was a really valuable insight that he had shared, and wanted to bring in my skilled nursing colleagues just to find out with that new insight whether there was any other way we would be able to help him. So I hand over to Kate.
As Karen said, he was tolerating most of his procedures really well when we were able to communicate with him, connect with him, and give him step-by-step instructions of what was happening. But we were finding that with the lumbar punctures going under GA, he was just still distressed and really hesitant to go under. So we really wanted to work with him to figure out what we can do to improve that experience for him. And he did reveal to us before what he revealed to Karen, that he didn't like the smell, he didn't like the taste that he had when he woke up. So we gave him and his mum the challenge to figure out what scent or what flavour they could use in the mask. And we could have it there when he woke up. And he came up with the idea of freshly cut oranges. So for his next LP, his mum brought in a bag of oranges, had them chopped up. He smothered his mask with the oranges. And then the bag was there when he woke up with his mum, so he could just smell them. And I think it did make a bit of a difference, but there was still that level of distress and hesitance in going into the GA room. And that's when he revealed to Karen that he was really worried that he wasn't going to wake up. And we just felt like that would be so traumatic for him and absolutely terrifying. So we sat with Mum and we spoke to her about some potential options that we could do to be able to support Frankie and improve his experience. And we thought that potentially, with how cooperative he has been, that he might be able to do this procedure without an anaesthetic. So we talked Mum through what this would look like, what pharmacological options there were aside from a GA, what non-pharmacological strategies we could use, and she was very much on board as long as Frankie knew exactly what was happening step by step, and he did have some control there. So we did mention this to him and along with Mum, and he was really keen to learn more about the procedure and what was required of him. So we remember quite vividly being in the treatment room. He was on the bed, curled up in the left lateral position. He had his oranges, he had his mum, and lots of questions, of course. And we talked him through what we would do, where the EMLA would be, where we'd be feeling. And he had a trial of the nitrous oxide, which he really liked. And he decided that, yeah, this is what I could do. And we went on to do a really successful procedure for him, and this was near the start of maintenance. So then he went on to have 10 cycles of maintenance, and all his LPs were without a GA. And I think as a team, like, we really learnt a lot from this experience, and it showed us the potential that we can really achieve when we have that true partnership with the families.
Thank you so much, Kate. And Karen, it sounds like it was a great outcome for Frankie and his family in terms of reducing the amount of GAs, which we know are very stressful for everyone around fasting and other things. But I think it also highlights a really nice point that when we're providing good family-centred care and we have those connections and partnerships with parents, that as healthcare providers we also have increased satisfaction in our job and the outcomes that we're providing, because we don't feel like we're causing that distress and trauma through the care that we have to give. So thank you so much. Very delighted to present to you Lucy Francazio, who is a survivor of cancer. Lucy was diagnosed with stage 3 anaplastic large cell lymphoma at age 11, and she's going to share with us her experience of the long-term follow-up program. Thanks, Lucy.
I just want to say thanks to PICS firstly for having me. As you just heard, my name is Lucy. I'm 19 now, and I was diagnosed with stage 3 anaplastic large cell lymphoma in 2016, this exact time 8 years ago. I was 11 and had been experiencing quite a few months of incredibly persistent leg pain that just kept getting worse by the day, low-grade fevers and fatigue that we now know were all signs of lymphoma. I started a pretty intense chemotherapy plan immediately after they determined what kind of cancer I had, and then finished in 2017. Although there were so many extremely challenging moments, one of the most positive experiences to come from me being diagnosed was meeting some lifelong friends who were doing treatment at the same time as me. One of the best things is running into them when they happened to be in the cancer centre for long-term follow-up appointments on the same day as me. Having progressed from hanging out all in the ward, hooked up to an IV pole, getting chemo together, to now only having a yearly appointment in the cancer centre makes us all realise just how far we've come. Me, when I first came off treatment and began the maintenance phase and was able to get back to gaining my strength, to help me see my friends, play footy, and do the things I love, it was the best feeling. Even little things like just not having to deal with presenting to emergency every other week or so with a fever made life so much easier. But in a lot of ways, it was also very challenging because overnight life went from planning everything around chemo cycles and side effects to having more freedom and energy to do so much more, but still feeling so behind everyone else because my body had just been through so much. It's hard to describe the way that childhood cancer blows up your life, but it does. An unbelievable amount of things change instantly, so just being able to return to some sense of normality after I finished chemo was amazing. Even though all the scans, blood tests, transfusions, surgeries and checkups still continue after treatment finishes. Shortly after this time, and before the long-term follow-up team contacted us, my health and well-being was greatly impacted by late effects caused by my treatment. About 6 months after finishing chemo, I started having chronic nerve pain. Some days it was manageable, and others it was so painful I couldn't even get up to go to school. Then a little while later, we noticed my cognitive functioning had declined. I began not being able to remember what I'd done at school that day. I wasn't able to recall knowledge in tests and really struggled concentrating for long periods of time. What really helped was the support from the long-term follow-up clinic that gave us the resources and information we needed to be able to greater understand the long-term side effects of chemo and how you can learn to live with them. Once I hit the milestone where I started having long-term follow-up appointments, my family and I had the best experience in my first appointment and every appointment since. I found that my clinic appointments felt tailored to me and my specific needs. It was obvious that the team understood what I had been through and made sure to place a big emphasis on understanding my current needs as I grew up and progressed through all my post-treatment milestones, but they were also great at preempting my potential future needs. And being someone with quite a few post-treatment side effects, I've gotten to experience lots of different parts of the long-term follow-up program. What I've always found super helpful are the treatment summaries and their roadmap information. The summaries have helped my other healthcare providers better understand my health needs. Also, the roadmaps have been so helpful in making sure my parents and I know exactly what different types of tests I need in the future, why I need them, and when I need them. A particularly memorable moment from my time with this program was coming to my appointment shortly after I had graduated high school last year. I got to come in and show all my medical staff pictures of what I had just achieved, and I saw how proud and happy they were for me. And I was so excited to share my achievements with them, as they all played such a huge part in getting me to where I am today. They played an enormous role in making sure my high school experience was as smooth as possible by working with my school to ensure I had the right modifications in place to help me thrive despite the post-chemo side effects I face. Whether it was liaising with my teachers about the importance of being able to take breaks to stand and stretch in class to avoid exacerbating my chronic pain during long periods of sitting down, or by making sure I had the right modifications in place when I sat my exams at the end of the year, the long-term follow-up staff made sure every aspect of my health and well-being was accounted for in all parts of my life. But more recently, the transition from the paediatric long-term follow-up appointments to the adult system was something I feel like I have to highlight. It was genuinely so easy and seamless, thanks to my clinical nurse consultant Heather Lang-Peach, Dr. Katie Moore, my long-term follow-up oncologist, and of course, my oncologist for the last 8 years, Dr. Peter Downey, who not only saved my life, but also has been there for every milestone since. Collectively, they all made sure I had the resources I needed so that when I was discharged from the program, all my questions about how the future of my care would look were answered. If I had to give some advice to any new patients or families starting in this program, it would undoubtedly be to make the most of all the amazing resources that are offered to you, as everyone is here to help you be as healthy and happy as possible. The program often involves a multidisciplinary team of health professionals for a reason that work together to ensure the next stage of your life post-treatment is as easy as possible. I genuinely gained so much from being part of the long-term follow-up program. It shaped my experience of being a cancer survivor in such a positive way that I'll forever be grateful for, as it has made this survivorship phase of my life so much easier to understand through the tools they equip me with to help deal with any side effects I've faced. Thank you.
Thank you so much, Lucy, for giving us an insight to your experience of long-term follow-up program, which is incredibly positive and really what we hope for young people who are moving through adolescence and into early adulthood and having to take on some of their own healthcare journey and needs going forward. And I think what you highlighted for us was, again, that patient-centric care can occur along with family-centred care where everyone was really supported, which was wonderful. I'm wondering if you paid Peter Downey for a special mention today, but can't talk about PICS without Peter, who is a great proponent of really family-centred care, and also Jane in setting up the program and looking at how to support everyone along that journey. Thank you, Lucy. We're now going to move to two of our clinicians from the Royal Children's Hospital, so Lauren Miller and Matilda Dawson. Lauren is a music therapist in the hospital and Tilly works as an art therapist within the Children's Cancer Centre. Thanks.
Yeah, and thank you to PICS for having us here today. Tilly and I thought it would be a great opportunity to just kind of have a chat about our roles and the way in which we work in a family-centred care model. So as Chinzia said before, I'm Lauren, I'm a music therapist, and I've been working in the Children's Cancer Centre here at the RCH for the past 11 years now. And so music therapy is a research-based allied health profession in which music is used to actively support people as they aim to improve their health, well-being and functioning. Specifically here in the CCC, music therapy aims to support patients and their families throughout their treatment. So we're utilising music as the tool in which to promote positive therapeutic outcomes across the domains of treatment support, mental health support and development. So this encompasses promoting positive coping strategies relating to elements of treatment, including hospitalisation and hospital-related trauma, distress, anxiety, pain, rehabilitation, and maintaining a healthy developmental trajectory. As trained professionals, music therapists utilise a variety of interventions to best support the needs of patients and their families. We work flexibly and with the ability to adapt in the moment in order to provide individually tailored programs that understandably evolve and shift due to the ever-changing needs of patients and their families throughout their treatment journey. So the music therapy framework It naturally complements family-centred care. It acknowledges not only the infant, child or young person themselves, but the encompassing context of the culture and family, their kin, the meaningful people in their lives who impact and influence their being. Often music therapy is referred in the initial phases of treatment, and it is the familiarity of music that provides a sense of safety, support and connection to patients and their families. The understandable shock and grief experienced by families upon diagnosis can shift dynamics and roles within the family units. Music therapy can provide opportunities for families to connect and reconnect to one another as they did prior to their diagnosis. Often meeting with patients and their families and discussing their music history and preferences leads to immediately strengthening those connections. Walls come down, they start to talk about their lives prior to being here in hospital. They make music together, they share music together, and they actively are remembering that they might have done this prior to being here and that they can still do this while they're here in hospital. Constantly see parents of infants and toddlers absolutely delight at the idea of again singing to their child, which often due to the stress of diagnosis, they almost forget that they've got this within themselves that they can access. It again strengthens that bond and it reconnects the parents to their primary roles. So that's as a parent to their child. I regularly receive feedback from parents, grandparents and caregivers that they love attending the weekly music therapy group as prior to their child's diagnosis. That this might have been the highlight of their week by attending something like rhyme time in the community. And it's great for them to be able to continue doing this here in the hospital. Similarly, in the art and music therapy groups that Tilly and I run, patients and their siblings or caregivers often initiate conversations in the sessions about their previous experiences with creative arts activities prior to being in the hospital. So at kindy or school, classes, etc. But this can also encompass the family's daily lives and their routines at home. In both group and individual sessions, family-centred care is embedded in the philosophy in which we work. So families can always engage if this meets their needs. So siblings, cousins, we've had visiting friends and who've all engaged in groups. It's the people who are meaningful in the life of the patient and the family that we're working with. Often I have family members, so parents, siblings, grandparents, that have called when they know that we're having music therapy so that they can join via FaceTime. Focus on supporting those pre-existing healthy relationships and provide modelling and education to strengthen family dynamics and relationships during a patient and their family's time here in the hospital. We also recognise that self-care is essential to supportive relationships. So whilst it's wonderful when families do want to actively engage in sessions, it's equally important at times for parents to attend to their self-care. And this is often able to occur when their child is happily engaged in activities like music and art therapy. So the strength of music and art therapy in relation to family-centred care is the ability to respond in the moment to the ever-changing needs of patients and their families throughout their treatment here in hospital and constantly provide opportunities for those connections. So I'll hand it.
Thank you, Lauren. And for those who may not have come across art therapy, I just want to speak very briefly about what it is. Art therapy is a creative arts modality that uses the process of art making to promote emotional, social and psychological well-being. We utilise the therapeutic process of art making and the visual object to explore thoughts and feelings outside of the body in an external form. Here at RCH, we are all registered art therapists that come to these roles with an understanding and skills to use the variable properties of art to hold space, regulate participants and support the flow of the session. Really, when Lauren and I got asked to speak here today, we were really reflecting over nearly our 7 years of working together, and very naturally we started thinking about some of the work that we did in the PICU and end-of-life space with siblings or cousins or friends or principals in the family space. And often these experiences for particularly siblings are the first time they may have come into the hospital. It might be the first time they've seen their sibling very unwell, and often is the first time the family unit has been intact after a long period of separation during the cancer journey. And so often we will hold a session at the end of the pod or, you know, outside of that hospital room so that young person can explore their thoughts and feelings about experiencing the hospital space away from their sibling. It allows them to have a sense of feeling special and engaged in the space and really able to tolerate what they're seeing and witnessing. We allow them to use process-orientated or non-verbal engagement. So they might be making art or music or a legacy piece to share with their sibling. And it can be really hard for these siblings or extended family members to know how to talk to that sibling. So, you know, we're really facilitating that communication in their moment, particularly if their sibling is intubated or actively dying. And for us, it's really about creating positive moments of memory making that is just not only an experience of pure grief. So yes, we hold a very privileged space. Thank you.
Thank you, Lauren and Tilly, and I think that's an excellent reminder that probably family-centred care is particularly and most important for families in that end of life and bereavement stage, and that our care really extends beyond the patient's life in that journey where we're actually supporting the family in their grief, which is unfortunately an experience for some families who come into our service. Now going to move on to our last speaker, but a very important speaker, and we just realised we went to high school together. Funny, a small world. So Natalie Khoury is mother to Sebastian, who was diagnosed with stage 4 Hodgkin's lymphoma in 2022 and received treatment through the Royal Children's Hospital. And Natalie's going to share some of the experiences, care, and some of the things that made a difference in that journey for us. Thanks.
It is a small world. Something that I haven't written, and I thought I'm not going to pivot off this because I don't want to forget what I'm saying, but something you said about involving the families and making us feel comfortable. So I had cancer 10 years ago, and every time, soon after I finished treatment, every time I went past that hospital, I actually could not look at it. So I would drive down Moreland Road and I would look straight ahead, and it was don't look left, don't look right, just go. Every time we drive past the children's, I don't have any negative, like I just look over and think this hospital saved my child's life. So I have very happy, sad thoughts, lots of emotions, but I've left here with no negative feeling because of what we went through. This was an amazing institution, and we thank you for what you do. So I'm Natalie. I'm a mother of 3 boys. I'm a wife to my husband, George. Our story is just one of many that this hospital sees. This hospital sees a lot of heartbreak, but they also see triumph. And what started off as a fairly typical day in our household was the worst day of my life. Hearing the words, "your child has cancer," is every parent's worst nightmare. And as much as we wanted it not to be true, our son Sebastian had stage 4 Hodgkin's lymphoma. So we knew life as we knew it was never going to be the same again. Before we even met them, the team at the Children's Hospital were with us to support us. 2 hours after getting that worst phone call of our lives, I had a phone call from a beautiful young fellow, Dr. Laura, who was there ready to answer the list of questions I have. I had a pink book, and Dr. Marty will know that that book came out with every appointment with a list of things. And, you know, we walk out with more questions than we go in, but they answered all those questions. It was 2022 and COVID was still happening and this hospital was still locked down. So there was very strict rules to parents, 1 parent, 1 child. But Dr. Marty and Dr. Laura always made sure my husband was there for those critical appointments, the appointments that I needed another set of ears, the appointments where I needed someone holding my hand. Rules, there was pivots to factor in what we needed. The hospital introduced us to support charities like Red Kite Challenge, Koala Kids, the Children's Cancer Foundation, and they made sure that Sebastian was keeping up with his studies as he was doing a VCE subject. The hospital organised for the wonderful Betty, who was a teacher who checked in regularly with Sebastian. She was a godsend, not just about being a teacher, but she would come in and say, Nat, go for a walk, clear your head, have some space, I'm here. And she'd sit with him, and sometimes they'd just play board games, and sometimes they'd study, but she was there to support us as well as help him through study. There were 8-hour chemo days, on some days back-to-back 8-hour chemo days, and the staff in day oncology always made sure that Sebastian had a private room on those days because he was very insistent that he wanted to keep up with his studies. And that year, after spending 6 months in hospital, we were in here 15 days on chemo, 15 days off. On the 15 days off, we're probably in here for a blood transfusion or antibiotics. So we're in here more than we're home. He got runner-up ducks of year 10. So this would not have been possible without the support of the teachers and the staff in day oncology. You know, we were introduced to the psychology team very early on in that first week. So they were checking in with us either on phone or in person. You know, you feel so out of your depth and you think the questions you're asking are stupid because, you know, the doctors are so educated. And what do I know? I'm not going to ask that question, so dumb. But my psychologist that I was speaking to empowered me. She made me feel empowered and I was able to ask those questions. I never felt like I walked away from an appointment and didn't ask the questions I wanted to ask. The hospital's team-based approach was invaluable. At first, we did consider taking Sebastian down the path of private consultation. But after discussions with Dr. Marty, I'm glad we didn't because 15 days into his treatment, Sebastian developed a bone condition called AVN, avascular necrosis of the bones. And it was the work of a team that worked together, of the best minds, coming together and working out why is this child in a wheelchair and can't walk just after 15 days. This was like unheard of so early. And it was this team that was able to work out a strategy moving forward to how do we continue with chemo but preserve his bones. And I feel like I wouldn't have got that if I'd gone down, you know, just one doctor. So I'm so glad we decided to stick with this team of experts. There were many trips to hospital. And during the time of, we were still in COVID times, the hospital made it many times onto the news to being at capacity. Ambulances were turned away. Sebastian was never turned away. We would go in there and we would not wait. As a child who was immunocompromised, he would be put into, they would find a private room for him even if it meant it was a room that had muesli bars. But we got treated just as well as we would have got treated if we were in a cubicle somewhere else. So they always found, the way they prioritised his care was like, I just can't explain. You know, I used to be that parent that if you rocked up to the hospital with a sick child and you were waiting 3 hours, I'd be banging on the counter saying, oh, hello, I've been waiting here for 3 hours, my child is unwell. I now have a new appreciation about the way you prioritise patients. So it doesn't matter my race, who I am, I was just prioritised based on what my child needed. I will not complain ever being in an emergency room again. I understand this now more than ever. So not only did they prioritise and look after Sebastian, my oldest son was doing year 12 and they proactively helped get special consideration because he was actually affected. His brother was going through chemo for 6 months while he was doing his year 12. So they proactively helped support us in the paperwork that was needed. And now they are doing that again for Sebastian, who has, because of the care of his team, he would like to be a doctor. So they are helping him with his application as he is now preparing to sit his final exams. This is truly a world-class facility. This is an amazing hospital. If only feedback I would have as a parent who struggled when our treatment ended was, I don't know about other parents, but Fast Track Clinic, which was our 000 number, was speed dial. It was on speed dial. It was in my favourites. And once treatment finished, I didn't know who to call. Was I allowed to call that number still? Like, what do we do? So I imagine a world where Fast Track is like 000. So when you're actively in treatment, that should be on your speed dial. but maybe, you know how the police advertise the no sirens, no lights? They have a different number you call for non-emergencies. Maybe there could be a transition period for parents to help support them, because emotionally, once the treatment stops, I think that's when the emotion starts. You're no longer in survival mode, and the wheels kind of do fall off at that point, and you become a bit crazy. So maybe that could be something that we could look into down the track. It would be wonderful as a parent to have that. This is truly a world-class facility, and we thank God that we've got this hospital on our doorstep. So thank you for everything you do.
Thank you so much, Natalie. I still see you using your Santa Maria debating cards, which they taught us really well in high school. But thank you. It's lovely to hear a really positive story despite the hardship and the distress and the horror that comes with a diagnosis, particularly when you've had your own experience. And I think that's something, we do have families where a parent has or a grandparent has experienced cancer, and remembering what kind of trauma and experience you come in and recognising that's a really important aspect of family-centred care. I'm just going to take 1 minute to say I'm glad to report that we are looking at an end-of-treatment model of care. It's called Emerge. We're doing it as a research program at the moment because we do realise that, again, parent wellbeing is particularly important, but focusing on parent and the child or young person as they move and transition out back to normal activities is really important. So I'm going to tap you on the shoulder to come onto our research team. It would be wonderful. Thank you so much to everyone for such an informative insight into both the experience of care and how we provide care to young people and their families, and again the importance of including everyone in that journey and the great outcomes that we can get when that happens. I'm going to open to the audience now for questions. There are some roving microphones, so if people would like to put up their hand. And for people online, you're welcome to put any questions in the chat. I might start off if no one has one to jump off with. I'm going to come back to you, Cheryl. I think Georgia just read that one. and your comment again about not wanting to make noise or make a fuss during your child's treatment. I wonder if you have any recommendations for us on how we might start that conversation with parents.
I certainly wasn't quiet about my feelings, but I wasn't going to say, this can't happen, this is not going to happen. I wasn't going to stop it, but I certainly was just not there. I just emotionally did not want to go through this. It would have been really good to have a phase between she's monitoring her diet, we're writing down everything that she's eating, what am I offering her as opposed to what she's actually eating. So we were going through that stage, but then all of a sudden it just went to the tube. There was no protein shakes or other dietary suggestions made. I just was a little bit shocked that it just went straight to that phase. So I think just opening up the conversation before you were thinking about going to that stage is this could be something we'll be looking at. If she reaches this particular weight, we may consider it. How do you feel about that? What would your family feel about that? How, what would be the situation? I think that would have been good to go through.
Thank you. Any questions from the audience? Any comments? John? Oh, thank you. Anna's coming.
Thank you, Chinzia, and all the panel participants. It's very valuable to hear everyone's experience and reflections. I wonder, this is to anyone who wants to answer, what in the current day we're doing about cultural and linguistically diverse families, perhaps those specifically who are first language different, perhaps like that? And also I noticed that there's no males on the panel. What do you think there's a different perspective to be had from fathers? How do you see that?
I'm going to put you on the spot, George, because we do have a father in the audience. I think it's natural for mums often to put up their hand, but
That was probably the decider between both of us, because he could.
And I look, our experience is that families are different, but the majority of mothers do take on the primary care role, particularly during treatment. But I wonder whether that raises its own issues of separation and sometimes guilt for fathers who have to work and can't attend all the appointments, and other issues that might be gender specific. Or
yeah, and I think a good opportunity for us to think about how we might include fathers now that we're using telehealth and other services more often. George, would you like to make a comment about that?
We went through our treatment during COVID, so everything was exacerbated because I couldn't get in a lot of the time. So I said Marty and Laura organised for milestones to be here. When they weren't milestones, we had them on speed dial. So it was also, Nat would go in, she'd have the phone on speaker and obviously ask before, and they were very accommodating, like get him on speaker, let's discuss it, make sure you're reassured. So yes, there is a process. It's about how you activate it, and it goes a long way, because then you're not trying to replay the information when you come back later. It's like, how was that meeting? Did you cover off all the points? And likewise, when I attended and Natalie didn't come because it was only one person, same thing, have them on speaker so that at least the partner's aware of what was discussed and hears it. So it's not like, oh, you've forgotten that, you should have done this, and then it creates that tension that shouldn't need to be.
I've just been told we've got enough time for one more question.
I just note, I think the cold families is really important area, and I think also understanding that different cultures have different family structures, different expectations of who might be included in that, and how much they want to be involved. You know, some cultures don't want to defer to doctors in terms of decision making. So I think it's about us understanding that and getting cultural advisors in really to help us understand what's the best way to present information and encourage their involvement in a way that they're comfortable. Any other questions? Are there any online questions? Oh. All right, well, oh, sorry. Kanika, please.
The patients and the parents who are on the panel. What was the most valuable thing, do you think, in that whole experience? The thing that made you think, this has really changed the way that I've dealt with this, because it's such a hard thing to do.
Maybe was there one experience that changed things for you, if anyone would like to answer that? Maybe for you, was there an experience for you that changed your treatment journey or the way that you felt you were, relating to the staff?
I think it was probably when I started noticing how much my chemo was affecting my everyday life, my functioning, and how I was going in school and how I was just progressing through all my milestones. I think it was when I started in the long-term follow-up clinic and they were like, okay, so we can get a pain doctor for this and we can get you to see a neuropsych for this and the OT will help with this. And they found me health professionals that could assist with all the different things the challenges I was facing after chemo, because I was relatively young when I was diagnosed and I wasn't really aware that all these things could happen post-treatment. Like I was like, oh, I'm healthy, I finished my treatment, everything is great. And then there's all these little things that you start noticing and these cracks and you're like, oh, actually, I can't remember what I did today, or I can't get up off the couch because my pain is so bad. But I think the long-term follow-up, delegating all of my different issues to people that I could then go and see and referring me to people, and even just having someone that knows all my different issues. Like, for example, Heather would know all my different post-chemo sort of side effects and be like, how's it going with your pain doctor, or how's it going with the OT, and have you had this test done, and all that kind of stuff, and how are these things affecting you. It was really good because someone knew everything and was able to kind of track it all and check that everything's like progressing how it should and that it's getting better, not getting worse.
Good reminder that care doesn't end at cure, right? That, you know, there's a very long journey ahead, and that's what PICS is all about. So I think that's a lovely point to end. Thank you, everyone, again for your contribution. Really invaluable for us to hear, both from people who've gone through the experience themselves and from our healthcare partners around how we provide care and areas that we can improve in. So thank you so much.
Thank you, everyone. Hopefully you can hear me. I'm a bit short for this microphone, I think. So my name's Kanika. I am the new Medical Director for PICS and the newest member of the PICS team. And I first just wanted to thank everyone on this incredible panel. I think your thoughtful discussion of your experiences, which would have been very hard for you to do, I know, was really thought-provoking for me and very powerful. I think it shows us how important that relationship is in providing the care that our families and patients need, and how valuable that is, I think, for all of us in our community together. So thank you very much. I'd like everyone to thank the panel for me if you can. Thank you. I'd also like to thank everyone for attending today. It's really wonderful to see such a great turnout. I did want to make some special mentions to our charity partners and supporters, so to the Sporting Chance Cancer Foundation, Koala Kids, to the Albury-Wodonga Regional Cancer Centre Trust Fund, to My Room, and the Children's Cancer Foundation. Thank you very much for all of your generosity and your hard work. It's obviously very valuable and provides or helps us provide the care that we need to provide. I'd also like to thank our colleagues in the Department of Health for their ongoing support of PICS. And finally, on the screen, you'll find a QR code, and that's for the PICS Strategic Priorities survey, and we'd love to hear from all of you as to what you think our priorities should be over the next 4 years and how we can help you achieve those. So thank you very much again, and thank you very much for everyone for being here. Thanks.